I'm going to talk about patient-inclined engagement and activation using various kinds of technologies, basically describing in brief some projects, several projects I've been working on over the last few years with community collaborators and technologists, and also hopefully get to be able to provide some pathways for technology development that you can connect with here at this conference. All right, so overall, this is kind of a vision of mHealth that my computer science colleagues have put together. But the vision is basically that our actions, whether they're self-report or monitored by some peripheral device or sensor, our self-reports and things like surveys, can all flow into what we might call experience sampling streams. And we're calling this small data instead of big data. But it can get aggregated and processed in the cloud into big data, and the idea is that we get visualizations and analytics, because the challenge with collecting so much data is that you're swimming in data that you never get to use, so we need to be building analytics integrated with the data collection. So I'm interested in this work, these data-driven feedback loops for patient-centered care or client-centered care. So what does that mean? That means that participants, clients, or patients can use their mobile phones to report data and also to receive interventions, like micro-interventions. This data can be viewed by a clinician and used in a clinical context or counseling their clients or patients, and it actually can be aggregated for research evidence as well, either for your own agency or even at a broader level. And we're really asking questions like, how is this medication or this treatment plan working for me? How is the patient responding or client responding to this plan? And what is working in different contexts and for different people? That's an overall. So I'm going to start with a couple of basic, simple platforms, so keeping it simple. Text messaging and automated voice response. So I've learned some things about text messaging and IVR over the past few years. So what are some advantages? So SMS text messaging, you can read and respond at any time. It's kind of asynchronous. The message stays on the phone, which could be problematic for some privacy things, but it can also be referred to again. There's no confirmation of receipt or reading of a message, so you really have no idea if somebody's actually been exposed to your message unless you ask for them to respond with pressing a 1 or 2 to respond that you've received it or answering some question about it. You need some basic literacy and technical savvy to use SMS, which not all populations have, but it, of course, may be preferred by many people over an alternative, which is interactive voice response. Now, for IVR, that's basically robocalling. So the idea here is that you have to answer the call, but there's no information left on the phone. There's automated confirmation of calls answered in duration. So we know if somebody answered the call, we know how long they listened to it for, so we can make a reasonable expectation that they were actually received the message that we were sending. Literacy an issue only for keying responses to queries, meaning if you want to ask some questions like, did you miss your medications today, or how have you been feeling this week? Press 1 for yes, 2 for no. And it functions on a landline, so if people don't have cell phones, it works there as well. Okay, so there's different ways we can go about administering or sending text messages or IVR messages. We can do things on a daily basis. We can do things at what's called event-based, which means you ask people to say, when something happens, answer a survey or send a message. And you can do kind of random assessments throughout a day. This slide's courtesy of Dr. Nancy Wu at UCLA, who's implemented this system with adolescents and substance abuse treatment. And what do they want? What are we monitoring here? What is she monitoring? She's monitoring affect, cravings, triggers, use, and sexual behaviors. So this kind of intersection around HIV risk and prevention. Now, mChorus is a platform for creating text messaging campaigns that I recently discovered a colleague at UCLA has developed, and Armin is maybe here in the audience. There he is, he's back there, and there's a table outside. So Chorus is a really cool platform for participatory development of a text messaging intervention. There's basically a website you can go on and you can author your own sort of surveys and interventions if you have a moderately savvy technical kind of IT support person. And you can build all kinds of timing triggering schemes with that, and they can be based on responses and so on. So this is stuff that people can do on their own, but it's also could be facilitated probably with a little bit of consultation from Armin's group from Chorus. If you want to find out more about that, Armin will be outside. We talked briefly about pricing, and I'm just going to say, I know everybody wants to know how much does it cost, right? So in general, when we talked, it could be something like $500 a month to $1,000 a month for hosting this messaging platform, depending on the volume of clients that you're wanting to send messages to and how frequently you want to send the messages. Very rough ballpark, but that's a general idea. And it's actually very similar to another technology company I'll highlight, which is Ohmage. Now, Ohmage is a global mHealth company, and I've worked with them extensively in India. And they have a platform called ComConnect, which is similar to the Chorus. It's a SMS and IVR system. Actually, the Chorus platform also does interactive voice response. So for the same platform and the same intervention, you can have either text messaging or IVR. Ohmage does the same thing. I think that their user interface is a little less user-friendly in terms of people being able to do stuff on their own. But they have an integrated case management system, and they can do they've done and developed some very technically advanced and savvy messaging platforms, which Dr. Reback will be presenting later on today. Basically, the idea is you can have automated messaging with real-time peer health educator messaging mixed in the mix. Okay, so then we can move beyond the keeping it simple point to the smart apps. Once we get into smartphones, we can start doing things like location-based triggers for surveys or micro-interventions and linking them with time. And we already know that apps like Grindr are kind of doing this stuff, which Ian will talk about in a little bit. So we can use those same technologies for interventions. And on an app, we can ask much more detailed questions that are much more user-friendly, and people can zip through the surveys much more quickly. What are we interested in monitoring? We're interested in monitoring, in this case, this is an example from a project I just launched with Kathy, with Dr. Reback at Friends, and it's working with methamphetamine using MSM in an outpatient treatment group. So we're looking at triggers, affect, cravings. Can also be symptoms if you're applying it in a medical context. It's whatever the domains of interest are, but in this case, these are the kind of primary domains we're interested in, as well as things like the actual behaviors and coping strategies that you might use. These are just some screenshots of some of our questions. So basically, you get a question, you hit the response, you confirm next, and you can kind of zip through a really fast survey, a survey pretty quickly. Okay, so I'm interested in self-monitoring for self-management. So the idea here is that just the fact of completing surveys on a phone, it's kind of like a diary. Whether it's once a day or several times a day or weekly or even monthly, has some potential impact on behavior change. And Dr. Lightfoot actually wrote a paper on this several years ago, back in maybe 2007, with computer-based self-monitoring for people coming in for their, I think, quarterly kind of medical appointments, that showed that just the act of reporting what's been going on with you over a period of time can help you to change. You become aware of your feelings, your symptoms, your thoughts, your actions and patterns, and potentially to change behaviors. So, in a pilot study that we did with people living with HIV and APLA, general population, not in any kind of a treatment or change program. We just basically gave people phones and said, here, let's try this for 6 weeks and let me know what you think. We saw that people reported that there was some improvement just from the self-monitoring. Medication adherence, about half reported that they improved their adherence, saying things like it keeps me on track or helps me take my medications on time. And in fact, people set up the alarms and the alarms for the medication survey intentionally as an adherence reminder. So we just said, we want to know if you're adhering or not, and they said, I'm going to use this as a reminder for myself. Okay, so also regarding stress and mood, more than half reported an increased awareness, and about a third reported some sort of therapeutic or cathartic effect from the monitoring, from self-monitoring. Substance use, a little less impact on changes, but the people were not all substance users, and not everybody was on a change plan for substance use, so this is a very kind of general population. And the same thing with sexual behaviors. Not a very highly active sexually active population, but people did report. So like this guy says, I saw no consistency in the names and I realized how many different people I was sleeping with. You know, the survey keeps me in check, specifically with monitoring sexual encounters. And this, in terms of change, that it helped me slow down my behaviors. And I took initiative to ask my new partner about STD status because they were being reminded on a daily basis about these issues. Things that they're actually committed to doing, but really it's our affect that often gets in the way of acting the way we really want to be acting. So what's the important lesson? Not everything needs daily querying. So a great quote is, stop reminding me how much sex I'm not having. So when you're asking people on a daily basis, did you have sex, and what kind? And people are saying, no, okay, so I don't like it. So the idea there is that for some things, we maybe only want to ask query maybe once a week, right? So as not to burn our folks out. Okay, so that was kind of the participant or client-patient self-care for the self-monitoring. So we had a visualization platform, but for that study with HIV positive people, but they weren't really interested in using it, and understandable, it wasn't very good. So next, I wanted to move into a kind of a clinical care context or application. So in other words, can we use the visualizations, 4 minutes, thanks, can we use visualizations from these surveys to help us monitor what's going on with our clients, with our patients? And will they use it, or can it be used in a counseling context to help support their behavior change goals? So here's a guy, he just started treatment, he's feeling really inspired, alert, excited, enthusiastic, determined. These are all positive affective states, right? He's really committed to his treatment goals. Then somewhere around here, these are red means more, like more inspired, blue means less. And then somewhere around here, he is not so inspired, he's actually getting tired, getting kind of fatigued, which we know is kind of a trigger for methamphetamine, people recovering from methamphetamine use. And we could look at the cravings and how those line up. We see these green dots are no cravings. And this is another participant with a different kind of pattern of affect and a different pattern of cravings. We can also look at their actual drug use, their sexual encounters, medication adherence. And actually so far, most of the guys that have enrolled, we're at about 8 people now, have been doing pretty good. So I don't have any great drug use plots to show you. So I've talked with physicians about this kind of stuff, and they're really hamstrung by the 15-minute reimbursable unit. So they're not particularly interested in opening up a whole can of worms with their clients, right? But substance abuse counselors, behavioral counselors, mental health specialists, dietitians, those kinds of folks would be interested in doing that. So what's a platform that we use for this? Ohmage is an open source platform developed partly at UCLA. There's a team of developers at UCLA, the Office of Information Technology. They also have a table outside. Ohmage has an ever-growing expansion of data collection apps. It doesn't matter which kind of mobile device you're using. Also, there's a new thing they're developing called Trial List, which is an N of 1 or single patient trial application for physicians out there. And there's various kinds of web-based visualizations and data management stuff. So we can give patients or participants feedback on their mobile phone with visualization. Also, we've developed this thing called live streams, which is an automated pattern detection program. So these are plots of people's sort of stress over time. And then you can see the change right here pretty easily when you look at it. But we've made algorithms that can detect this. So what do we do with that? This can now be used to trigger intervention. So somebody's monitoring, they tell you what's going on, they have some stressful events, our algorithms detect it and then can send automated interventions to that person. Like, hey, talk to your counselor, here's some stress reduction strategies. This is kind of the future of where this kind of stuff goes. And 1 minute, so just the final kind of topic is about care coordination and case management. But basically, these kinds of data streams, we can have folks like data collectors or community health workers, peer outreach workers using mobile phones. And that data can all be kind of moved up through a chain of data management for supervision and support, and also fidelity monitoring. And this is from a project in South Africa with home visitors. But basically here we're kind of doing fidelity monitoring support. So we're looking at whether they've kind of delivered specific content, how much time they're spending with the client, and this information is then used for problem solving and case management support. And Ohmage is a company that really specializes in this kind of case management application stuff, and I'm working with them in India with sex worker peer outreach workers on adapting their onerous paper-based forms into a electronic mobile phone-based case management system. Now, pricing is the last thing everybody wants to know about pricing. So this is from Ohmage. They're one of the few that I think actually post pricing. They get a lot of questions. So as mentioned by Indu earlier, it's open source. They're a B Corp. They're a social benefit. You can do stuff for free, which has basic functions, if you have some technical capacity to do it. If you want some support in development, it might cost something like $25,000 for some basic support to up to $100,000 to do something really fancy, really technical. Mostly I've been actually finding my work with them is somewhere in between is around $50,000. And that's to develop new features that are not currently part of their platform. Thank you for the stop. And then they have monthly plans that are kind of maintenance plans, which can run between, what is it, $500 to $1,000 a month, depending on how many outreach workers, if you're on that tip, or how many messages you're sending to your patients or clients each month. So I hope that was helpful in giving some people some inspiration and ideas on how these kinds of things work. And thanks.